our winter break and because of COVID, but we're back and up and running. So we're thankful today to have Dr. Brooks Bond here with us. He's one of our UAB endocrinologists. He's always stood out to me as one of our outstanding clinicians and educators, even as a resident. He's MedPeds trained, by the way. I have to put that plug in there.
Yes.
I know recently too, he's been staffing the Tinsley Surge service, and helping offload our service. So we thank you for that as well. And we thank you for your contribution to the educational efforts of our service. So with that, I will let you get started.
Thank you. And I think deliberately this should not, definitely shouldn't go over, and should be leave a little time for conversation. And I am usually pretty good at looking at the chat and answering questions along the way. Let me make sure I've got that pulled up. So if people want to put questions in there as I move along, I usually can answer, and I'm happy to do so. All right, let's see. Whoops. Okay, so what I'm going to talk about are probably our two most common serious endocrine emergencies that we get called about. I think the most common endocrine emergency in UAB hospital is DKA, but that tends to go to the unit team. And honestly, we don't tend to get involved with that until they're ready to come out to the floor. So what we get called about on the floors into the hospital service fairly commonly is severe adrenal insufficiency. Sometimes people actually have it, sometimes people don't. We'll talk about that. I think diagnosing that is kind of the tricky part. Treatment's not too complicated. And then severe thyroid dysfunction. So hyperthyroidism or thyroid storm, and we'll talk about how that term gets thrown around, and myxedema coma. And I will say part of the reason I went into endocrine is, to avoid mortality. That's one nice thing about endocrine. But these are probably the handful of diagnoses that over the years I have seen mortality. So these can be pretty severe, and thyroid disease in particular has probably been the cause of the most deaths that I've actually been involved with. So it can be pretty bad. Okay, so the term, so just some nomenclature that might help you maybe sometimes when you're filling out patient keeper or doing diagnoses. The term thyroid toxicosis actually refers to any excess thyroid hormone of any cause, including exogenous thyroid hormone consumption. When we say hyperthyroidism, we're actually specifically saying that that's coming from the thyroid. So just a little bit of trivia, but that's a nuance there. Adrenal insufficiency, as I mentioned, we think about it a lot, and sometimes it's not present. And on the flip side, we probably miss it sometimes because it's quite common in our hospital. Primary adrenal insufficiency, so that's Addison's disease, or actually adrenalectomy or destruction of the adrenal glands themselves, is pretty rare. We don't see that much. However, secondary adrenal insufficiency is really common, and the most common reason really is exogenous steroid use, particularly in our sick patient population. So our patients on prednisone for COPD and rheumatoid diseases fairly commonly get secondary adrenal insufficiency. So what I'm going to do to hopefully spice things up is I'm going to go through, I think, 3 or maybe 4 questions. And I am not going to ask for answers. We'll go back and do the questions at the end after we finish the talk, but this will give you food for thought. So the first one is you're called to the ER for a patient with sudden onset headache and hemorrhage into a sellar mass, so a pituitary adenoma. So basically this is a patient with apoplexy, which we get a few of these every year. And the patient is hypotensive. So what do you want to do? Do you want to tell the ER team to give fluids only when they send the person up? Do you want to ask the ER team to do a cortisol stimulation test, start fluids and hydrocortisone? Do you want to start IV levothyroxine immediately? Or do you want to start stress dose hydrocortisone with IV fluids? So we're going to come back to this. Okay, another patient. Let's alter this a little. Let's say it's a patient admitted to you out of clinic who's being treated for breast cancer. She's had intensive chemotherapy, but she's in remission and was doing pretty well. At one point, she was put on Megace to stimulate her appetite, but it was just stopped. And so she comes to the clinic with nausea, malaise, joint aches, and hypotension. You do a cortisol stimulation test, and you get a peak of 12, and her ACTH is 0. She responds nicely to hydrocortisone replacement. And so as you're discharging her, let's say she's on your service, do you want to leave her on hydrocortisone and wean her off at some point in the future? Do you want to scan her head for metastasis to the pituitary gland? Do you want to scan her adrenals for bilateral adrenal metastasis of her breast cancer? Or do you want to start fludrocortisone in addition to hydrocortisone? Okay. All right, next one. You admit a patient to the floor. 6 days ago, let's say Dr. Vaughn gave him a radioactive iodine ablation for severe Graves' disease, and he's now tachycardic and tremulous. Which medications do you want to start in which order? So look at those, and what I'll tell you is there's one wrong answer. And so the drugs in question are beta blockers, SSKI, so that's supersaturated potassium iodine, methimazole, or steroids. So those 4 drugs, which order, and one of those is wrong. I'll come back. All right, I think this is the last one. You're on call in the ICU. A nursing home patient is brought unresponsive and apneic. They have an obvious thyroidectomy scar, but no thyroid meds on their med list. A med student calls the facility and discovers that levothyroxine was left off after a transfer from one nursing home to another 3 months ago. The patient is hypothermic, bradycardic, hyponatremic, has a TSH of 150, and a free T4 that's undetectable. Which of the following do you want to do first? Warm the patient with a warming blanket immediately. Start boluses of T3, 100 micrograms every 8 hours. Start levothyroxine, 300 micrograms once with a 10 microgram bolus of T3 twice a day. Or admit the patient to the floor given the excellent prognosis of this condition and just start oral levothyroxine. Okay, so we're going to come back and do all these questions. All right, so adrenal insufficiency, as I mentioned, primary adrenal insufficiency, which is most commonly Addison's or adrenalectomy, is severe. So these patients have severe lack of cortisol. And upon new diagnosis, about half of these patients present in crisis. So this is very uncommon. Secondary adrenal insufficiency, however, is very common. Again, are patients with glucocorticoid use for other reasons typically. And one key distinction between these, and the reason you really do want to figure out which one you're dealing with, is if the patient has secondary adrenal insufficiency, so that's inhibition of ACTH, therefore poor production of cortisol, they will have intact mineralocorticoid axis because the renin-aldose system is completely not under the control of the pituitary gland. So these patients should not need fludrocortisone and typically won't have hyperkalemia. They do occasionally have hyponatremia, and we can talk about why, but they don't get hyperkalemia that you see with primary adrenal insufficiency. So it's worth distinguishing them because the therapy is a little different. Okay, so I'm going to spend about the next 30 minutes on this slide. I'm just kidding. But this is the adrenal axis, or the adrenal production pathway that we all learned in med school. But just the key here to remember, so when we talk about adrenal insufficiency, primary, secondary is a really important distinguishing discussion, because if the adrenal gland is damaged, you're going to lose aldosterone and cortisol. But if the pituitary gland is the problem, you're only going to lose cortisol, no effect on aldosterone. And what do glucocorticoids do? So they maintain our sensitivity to epinephrine and norepinephrine at the receptor. And therefore, if you don't have it, you really can't maintain your blood pressure. And so vasoconstrictor agents aren't terribly effective if you don't have sufficient cortisol production. Okay, and then again, just remembering that aldosterone and just the aldorenin axis, and just this all takes place in the kidney in response to blood volume. Pituitary gland is completely out of the loop here. That's really all I want you to remember from that. Okay, so I will ask a question. These are the two most common causes of primary adrenal insufficiency, so kind of bonus points. If anyone can get what's on the left and what's on the right. Somebody put it in the chat if you can take a guess. So the left is the most common in the world. The right is the most common in the US. Anybody know what the pathologies are? Yeah, so TB is the most common on the left, in the world on the left. And then on the right, that's lymphocytic infiltration of, on the right, of Addison's disease, so autoimmune disease on the right. Until last year, I would have told you I've never seen adrenal insufficiency from TB, but there was a patient, I don't know if any of you guys saw him, from rural Mexico that was on the Tinsley service sometime this year, who had POTS disease and did have adrenal insufficiency from TB. I had never seen it before. Not common in the US. Okay. So common causes of adrenal insufficiency, again, this is common causes for a relatively uncommon disorder, especially if you're talking about primary adrenal insufficiency. So again, adrenal destruction. So autoimmune adrenalitis in the United States, and that's Addison's disease. TB, which I don't see much. I have seen metastases to bilateral adrenals. That can certainly do it. And then we've got a handful of patients in the endocrine clinic and a great med-peds topic with adult, kind of adult folks with congenital adrenal hyperplasia that was diagnosed at birth. Bilateral hemorrhage, not common, but I've seen. Adrenalectomy, occasionally we do that. And then adrenal leukodystrophy, not common. I've got one patient with that. But so these folks have primary adrenal insufficiency. Secondary, so pituitary disease, which we see a fair amount of. Other tumors or radiation to the area of the pituitary is pretty common cause of this. But the big one by far is right here on the bottom, is long-term exogenous glucocorticoid use. And you'll see different data on this, but the rule of thumb is 10 milligrams for 3 weeks is all it takes. 10 milligrams of prednisone for 3 weeks is probably enough to suppress the adrenal axis and cause someone to fail a cortisol stimulation test. Now, the majority of those patients don't develop clinical signs and symptoms of adrenal insufficiency, but they do if they're under stress. So that's where you folks as hospitalists just need to have your antenna up, because it just is surprising. If I think about this, surprising how little steroid could cause someone to then get a severe community-acquired pneumonia, come into your service, and really have clinical signs and symptoms of adrenal insufficiency because they're stressed and now they're not mounting that response. These are classic physical findings for primary adrenal insufficiency and specifically Addison. So because it's autoimmune, you often also see other autoimmune disorders, and vitiligo is a common one. You also sometimes see primary hypothyroidism. But again, in these patients with glucocorticoid-induced adrenal insufficiency, they're not going to have any of these findings. In fact, sometimes they look a little cushingoid because they've been taking a lot of steroids. So you have to really have a high index of suspicion. And frankly, the physical exam is not very helpful for glucocorticoid-induced adrenal insufficiency. And then these folks get gingival hyperpigmentation, and that's because there's a precursor molecule to ACTH called POMC, propionimelanocortin, that pigments the skin. So that gets produced at high levels and the skin gets pigmented. And then this is just an example of an Indian woman. On the left is pre-treatment. She has Addison's, and on the right is post-treatment, and how dramatic those skin changes can be for the patient. That's just this diffuse hyperpigmentation you can see with primary adrenal insufficiency. The big test there is often to really make sure that they have this, you need to look at non-sun exposed areas. Because I've been fooled before with folks looking really dark, so I think they have adrenal insufficiency compared to some old pictures. Turns out they're just sun exposed. So the trick is you need to look in non-sun exposed areas. But then I've also been burned by people who get in the tanning bed naked. So then they have very uniform darkening of their skin. And I've been burned on that. All right, so signs and symptoms of chronic adrenal insufficiency. Typically with primary, so more severe, you get fatigue, anorexia, and weight loss. And so this is a good clinical pearl, is that one series of people with primary adrenal insufficiency, so if you're thinking someone has Addison's disease, there's one series published that every patient in that series had some degree of weight loss, unexplained. So if you're talking to a patient and you think about you're thinking about adrenal insufficiency and they have not had any unexplained weight loss, you've probably ruled out primary adrenal insufficiency, but certainly they could still have secondary adrenal insufficiency. And paradoxically, a lot of those people have weight gain because we're giving them these steroids. So again, history is not as helpful for them. And these folks get orthostatic, again, primary adrenal insufficiency. They get orthostatic hypotension. They can get hyperpigmentation. Salt craving is a fun thing to ask about when you've got one of these patients with primary adrenal insufficiency. So I had one patient who was going to the refrigerator and drinking the juice out of the pickle jar whenever somebody bought pickles, and her husband was complaining that the pickles were drying up because there was no juice in there anymore, but she was craving that salt in there. And these patients get hyponatremia, and then they get hyperkalemia because they lack aldosterone, and occasionally they get hypoglycemia. So if you guys have admitted a 72-hour fast for us, which I know many of you have, we typically, if the patient hasn't had one, we'll do a cortisol stimulation test to make sure this is not a cause for hypoglycemia. And then if they get into adrenal crisis, things get more severe, and they can lose consciousness, get hypotension, etc. Okay, so what causes people to have a crisis? So one thing is just people with known AI, so known adrenal insufficiency. And the most common cause for a hospital admission for someone with known adrenal insufficiency is simply gastroenteritis. So my patients, I have tons of patients with adrenal insufficiency, mainly because of pituitary tumors. And the big caution we give them is if you get vomiting and diarrhea, which is we all get once in a while, that becomes very dangerous for those patients because one, they can't take their steroids, and two, they're becoming dehydrated because of the diarrhea. So we equip those patients with a emergency hydrocortisone shot. And it's really important if you're prescribing one of these on discharge, we like these, it's called the Solu-Cortef Acto vial, which is a pre-mixed vial, which does not, if you just order an injectable hydrocortisone, the patient may get a powder that's got to be mixed separately with saline, and patients can't figure that out. So there's a pre-mixed thing called an Acto vial, and we give those patients with known adrenal insufficiency, that is their sick day toolkit. And we tell them if you're vomiting, someone in your family needs to give you this, or you can give it to yourself on your thigh if you can, but usually we expect a family member to do that. And then we tell them you need to come to the ER right afterwards. And our goal there is to really keep them out of the hospital. They may need some fluid resuscitation in the ER, but if they've given that shot, usually it doesn't get to the point where they come in. And then the other typical cause for an adrenal crisis is stopping exogenous steroids. So glucocorticoid therapy that gets stopped and then they get sick. Fluticasone, which is inhaled steroid, has been described to do this. Megase has been described to do this. So Megase has action at the glucocorticoid receptor. So this is kind of a forgotten glucocorticoid. So there's lots of reports of people stopping their Megase and getting quite ill if it's not tapered. And then just remember, exogenous steroids are come in many forms. So there's inhaled, oral, which everybody thinks about oral, and then the interesting ones that we've gotten burned on are people with heavy-duty skin creams for psoriasis, for example, or people are using skin steroids inappropriately. And then injections. So a big one we run into is epidural injections to the back or hip or joints. They're being done repeatedly, and the patient's got lots of steroid in their system and not really realizing it, and then they get ill and they get stressed and they have an adrenal, they develop clinical adrenal insufficiency. And then occasionally thyrotoxicosis can trigger this, not common. Okay, so let's talk about treating adrenal crisis. So fairly straightforward. It's fluids and steroids. And we certainly, if this is something you highly suspect, you would never be faulted by just treating it and sorting things out later. I would always, if you have the presence of mind and somebody you think's got adrenal crisis, to just get a random cortisol before you start the hydrocortisone. And even an ACTH would be even better. But if you can just get a cortisol, it's helpful, because then afterwards, if we see that that's a very robust cortisol level before we treated them, we can reconsider. But we can always sort this out later. So aggressive normal saline or LR, and certainly you want to give a nice bolus, so about 30 cc's per kilo, so about approximately two liters typically to get started. And then 50 milligrams of hydrocortisone IV or IM every 6 hours is plenty. So the quality of data on recommending or telling you what stress dose steroids are is terrible. Nobody knows. All we know in terms of really studies is that historically we gave way too much. So used to give 100, 200, 300 milligrams Q6 of hydrocortisone, and that clearly, there is some data that's associated with more adverse outcomes. Really 25 Q6 is probably enough, but 50 is fine. So 50 Q6 hours. And you don't need to give someone a mineralocorticoid in the acute situation as long as you're using hydrocortisone, because hydrocortisone at higher doses has mineralocorticoid activity. So you don't have to worry about giving fluid or cortisone to someone acutely, even if you think they have primary adrenal insufficiency. But you would want to initiate it on discharge, because long term they'll probably need it once they're stable. And then it's just worth remembering that some steroids have no mineralocorticoid activity whatsoever. So this won't come up on hospital medicine much, but as you guys know, certain specialties love other steroids, dexamethasone for ENT and neurosurgery, and those steroids have no mineralocorticoid activity. So if you really think someone's in crisis, you don't want to use dexamethasone. You'd rather use something that's got mineralocorticoid activity at higher doses. Okay, so this, you've got to have questions about this, because this is probably our number 2 most common consult. So please just pause, speak up, let's talk in the chat, because this is something that's tricky even for our fellows, and it's sort of interesting to talk about, is how to diagnose adrenal insufficiency. So I'll tell you our classic test, and then what we ought to talk about is how a random cortisol can help. So our classic test is the cord stem. So, whoop. Did I lose? We okay? All right, somebody tell me if you can't hear me. I just heard someone say, uh-oh. I'm just making sure.
I think we're good. I can still hear you and see everything.
Okay. So the classic test is the cosentropin stimulation test. And if you look in literature, you can see descriptions of a 1 microgram test. We've abandoned that. It's just too hard to, the drug doesn't come in that preparation, so you have to make it. And it's been shown that lots of errors can happen. So we like the 250 test. And you can give this IM or IV. And you want to get a cortisol at time 0. And then you want to give the injection. And it's worth remembering that all that matters is you need to get the second one an hour after the injection. It does not have to be an hour after the baseline test. So all you really care about is giving the shot and then getting in an hour later. I don't care if the first and second ones are an hour apart. It's the shot that matters. And there's good data that you don't really have to do a 30-minute test. So I would never fault anyone for doing a 30-minute test, but the data suggests almost always you get the information you need with the 60-minute test. So we like time 0 and 60, perfectly good, a little more practical. And what you're looking for, bottom line, is a cortisol level of 18 or more at any point in the test. There is no data to support a delta that's appropriate. So this comes up a lot sometimes in the hospital, comes up a lot in the ICU. So a few years ago, it was very much in vogue to, the ICU literature had this whole body of studies about the delta on a cord stem and what it meant and how to stratify those results. And it turned out that all those data came out of one group in Belgium. No one could replicate it anywhere else. And so it's really just gone down the toilet. So right now, all we can tell you is if it's 18 or more, any point in the test, normal. And you can tell from the results what type of adrenal insufficiency people have typically. So people with primary adrenal insufficiency will flunk the heck out of these tests. They'll go from 1 to 3 or 0 to 2. But people with secondary adrenal insufficiency, so your person who's been taking prednisone for months, will typically do something like 5 to 13 or 4 to 12. They'll mount a response, but it won't be very good. So that's how we use the quart stem. And the time of day that you do a quart stem doesn't matter because you're artificially manipulating the adrenal axis anyway, so you don't care about time of day. So I'm going to stop here because this is super common. So there's got to be questions. And so I guess my question would be how to interpret a random cortisol. So anybody want to venture how a random cortisol is useful? Because we all do this sometimes. We just get one to kind of see. How do you guys use it? I have to pick on Ashley. What do you do with random cortisols?
It's okay if you pick on me. I guess if it's elevated, if it's above 18, or if it's elevated, then
yeah. So that's the perfect answer. So the only use of a random one is if it's over 18, you're done. You don't need to do a quart stem. So your question is answered. The problem with random ones is a healthy person in the mid-afternoon could be very low, 2 or 3, and that's not abnormal. So on the low end, they're not very helpful. So randoms are helpful over 18. And then morning ones are helpful if they're less than 5. They make me suspicious, but I would still do a quart stem. So I would not put someone on a lifelong glucocorticoid replacement based on one morning cortisol less than 5. But if it was less than 5, I would be interested. But everything, and on a morning sample, anything between 5 and 18 is uninterpretable. It could be normal, could not be normal. So you're still stuck doing a quart stem. So the two pieces of information that are normal outside of a quart stem are a low morning and a higher random, or a random over 18. Okay. All right, so I'm going to switch gears to thyroid, and then when we go to the questions, we'll have lots of time to ask questions. All right, so our two thyroid emergencies, thyroid storm and mixed edema coma, both with kind of exciting names. So here we're kind of comparing and contrasting the two. So on the left is mixed edema coma, by far and away the most common reason I've seen mixed edema coma, typically a nursing home patient or an elderly patient who runs out of Synthroid, they don't refill it, and they get real sick. Interestingly, I trained in Minnesota. Cold temperatures seem to bring this out, and there definitely was a seasonal tendency for folks to come in with mixed edema in the winter more so than other times of month. So it just aggravates things. And then there's a huge variety of things that can set it off. So the other scenario where these patients come to attention, bottom line, is if they're walking around really hypothyroid, and then they get any kind of insult, so infection, sepsis, heart attack, heart failure, and it just sort of tips them over into problems. And then on the flip side, thyroid storm. So the most common cause of that is a known patient with Graves' disease who doesn't take their medicine. So we have had several examples of folks repeatedly coming in with thyroid storm. It's usually a patient who won't take methimazole. The other cause is iatrogenic, meaning I did it. I've caused it a few times with the radioactive iodine because folks tend to get a little worse before they get better. Never seen somebody put themselves in storm on overdosage, but you in theory could. And those are the big ones. The other ones are getting pretty rare. Okay, the reason I have this slide on there is just to remember when you're treating hyperthyroidism and hypothyroidism, that the molecule that really where the money is T3. And we kind of tend to forget that. So T4 is made by the thyroid in about 85% quantity, and then about 15% of what the thyroid makes is T3. Most of the T4 then gets converted to T3 in the cells or in the tissue, But T3 is what crosses into the nucleus and acts at the receptor. And so that's what causes thyroid symptoms, either high or low. It's either lack of T3 or too much T3. So it gets a little underappreciated because we tend to check T4s, but T3 is where really the money is. And so T3 ends up acting in the nucleus, and messenger RNA is expressed after T3 stimulates things, and it's either expressed or not expressed, depending on if you got it or don't have it. And it really affects every tissue in the body, but the ones that we tend to see are the heart. The heart has lots of thyroid hormone receptors, and it's highly affected by that. Metabolism, and then ventilation. So this is where people get sick, is with lack of ventilation if they're severely hypothyroid, and then thermogenesis and sweating. So those are the symptoms we tend to see. Another source of trouble for us just is iodine, and I love this chart because it just shows you how much freaking iodine is in amiodarone, which is my least favorite drug. So you could eat iodized salt all day, 380 micrograms of iodine, and look at the content per tablet of amiodarone, 75,000 micrograms. So amiodarone is just a bomb of iodine that patients are taking day after day after day. So the iodine load is really incredible. And that's part of the source of trouble we get from amiodarone. So when to check thyroid function test. Anybody who looks septic with no etiology, thinking about hyperthyroidism is not a bad idea, and adrenal insufficiency. Both can kind of cause fever, tachycardia, those type of symptoms. Thyroid tests, though, as you guys know, are tricky in sick patients. And so what I tell people, if you're checking thyroid tests on a sick patient, I don't object, but basically I can tell you if they're really hyperthyroid, and I can tell you if they're really hypothyroid. But there's going to be this huge group of people in the middle that I don't know what they have, because sick thyroid has been described to present in almost every possible pattern of thyroid function. And it's usually just contradictory labs. So if somebody's really hyperthyroid, the T4, T3 are going to be up, TSH is going to be down. Opposite, if they're hypothyroid, TSH will tend to be up, others will be down. But there's just going to be this batch in the middle of sick folks that I don't know what to do with. So just think carefully. What a lot of folks would say is if you want to sort of get the most useful lab, is give a TSH only if you're trying to rule out severe hypothyroid. And if it's normal, you can probably stop there, because if you keep looking, you're probably going to find out this person's kind of in the middle with these difficult to interpret thyroid tests. So TSH is a good way to start, particularly in sicker patients. Okay, so treating severe, can you remind me how thyroid steroids affect TFT? So they do two things. So sometimes an acute steroid bolus can cause a brief transient TSH suppression. So we see that sometimes. But the classic thing, and this will come up in a minute in treatment, is that it inhibits T4 to T3 conversion. So we actually take advantage of that when we're treating severe hyperthyroidism to inhibit T4 to T3 conversion. So that's why we like glucocorticoids with hyperthyroidism sometimes. And that's why I was emphasizing that the money is in T3, because that's the hormone that gets blocked there. And I'll go over that explicitly here in a second. So when you're treating thyroid storm, and I'll talk about that word here in a minute, there's only one really big mistake you can make, and that's think hard before you give anybody any kind of iodine, including contrast. Because if the patient's got severe hyperthyroidism and there's no thionamide on board, that iodine can be used to make more thyroid hormone. So you could really make somebody worse. And as long as you got your thionamide on board, so thionamide is an anti-thyroid drug, methimazole or PTU, you've stopped the factory at that point, and then it's safe to give iodine for these other reasons that I'm about to go. Okay, but that's the one thing you don't want to do, is start with iodine. Don't do that. Beta blocker and thionamide are kind of your go-to. And the beta blocker is just for symptoms and to protect the heart, and then your thionamide should be started next. And you can be very generous with the beta blockade. We tend to be a little wimpy with that. It's my impression when I see folks on consults. We can be real generous, and I would just aim for just start out aiming for a pulse under 100. These folks can come in really tachycardic, and in the unit we like an esmolol drip that can be titrated. And the good news is you typically don't need to make a diagnosis. So occasionally we get asked, should I be doing an uptaken scan or an ultrasound before I start treatment? And I'll tell you, the only reason you even need to do that is because if somebody has thyroiditis, then they won't respond to methimazole. So thyroiditis is spillage of preformed thyroid hormone, and methimazole doesn't help that because methimazole stops thyroid hormone synthesis. But if you're already spilling it, cat's out of the bag. But I'll tell you, most people don't get in the hospital with thyroiditis. Thyroiditis tends to be more mild. So almost everybody who's in the hospital because of thyroid dysfunction, most of the time they're going to be having endogenous hyperthyroidism or overproduction out of the factory. And a thionamide is going to be a good call. And if they don't, thionamide is not going to hurt them. So we don't need to worry too much about getting the diagnosis acutely. So let's talk about thionamides. So there are no produced IV forms commercially, but they can be made. So if you Google this in an emergency, there are descriptions of how the pharmacy can basically cook up some homemade IV PTU or methimazole. And it's not that hard to do. I've done it one time, I think. It can be given by enema, but this is pretty rare that you're going to need to do that. And so your two choices are PTU and methimazole. PTU has a theoretical benefit of inhibiting T4 to T3 conversion, but there's not a lot of clinical data that matters much, and so we tend to use methimazole. There are, though, folks who still advocate for PTU in critically ill thyroid patients in the ICU, but that's debatable. So for practical purposes, we don't use it, and I'll talk about the exception. So how much methimazole to give? And so this is actually in up to date, and I was glad to see it because this is kind of my gestalt. Mild 5 to 10, moderate 10 to 20, severe 20 to 40. Okay, so and you can use your free T4 levels, how high they're elevated, to make that judgment. And if you're using more than 20, you can divide it. So you could, if you're using 40 milligrams, you can divide twice a day. But less than that, you can just use it once a day. There's no reason to split it up. One big caution, I have been burned on this, is particularly if you're discharging a patient on methimazole, impact defaults to TID dosing. So I have overdosed a patient before, meaning to start 10 milligrams daily, and impact defaults to TID, which is really a problem, and I've never been able to get it fixed. So be careful about that when you're discharging patients. I don't know what happens on the inpatient side, but the outpatient does that. Okay, so most patients who come in the hospital with hyperthyroidism just need beta blockade and a thon. In terms of beta blockade, there's nothing magic about propranolol. In fact, I don't like it very much because it's TID or QID, or you can get the extended release, but it's too much dosing. I like atenolol. I don't think atenolol is on the inpatient formulary, but for outpatient use, I love it. Once a day works fine. The theoretical advantage of propranolol is it just helps with the peripheral symptoms, the tremor, a little more than atenolol does because it's non-selective, but it's just not clinically very important. And then ill patients, we start thinking about second-line agents like iodine and glucocorticoids or bile acid sequestrants. I'll talk about that. So why iodine? Sure, it seems counterintuitive. So it only works if the factory is shut down, meaning you need that thionamide on board to stop production of thyroid hormone. But if you've got that on board and you give enough iodine, you get this Wolff-Chaikoff effect. And basically the thyroid perceives this huge load of iodine. It cuts down on the iodine transporters that are at the cell membrane, and you get a temporary diminishment of thyroid hormone production. You want to give that after the thionamide, and the typical way to give it is SSKI, 5 drops every 6 hours. Glucocorticoids, you can just give stress dose. You can give 100 TID or 50 Q6, and that inhibits T4 to T3 conversion, can be very helpful acutely. And then in Europe, they have an oral contrast agent that you can use. We don't have that in the United States. And then glucocorticoids, you always want to consider if you think it's a patient who might also have coexistent adrenal insufficiency. And that's plausible because some people with Addison's will also have primary hypothyroidism. Some people with adrenal insufficiency, if it's from a pituitary tumor, will also have central hypothyroidism. So you can think about that if you're treating someone with a severe thyroid disorder. Glucocorticoids are not always a bad idea. And then don't forget emergent thyroidectomy. So I've had to refer 2 or 3 hospitals, particularly if the patients come in for the second or third time in a hyperthyroid crisis to our hospital. I always start thinking about emergent thyroidectomy. Plasmapheresis has been described to work as well. I've not done that in a patient, but that is a sort of last-ditch effort for somebody who's really hyperthyroid. But the people who I would think about for emergent thyroidectomy are non-adherents to their medical regimens and multiple admissions. Occasionally have to do it for severe hepatic injury on thionamides, or if they're not responding to therapy. The surgeons don't love that phone call because it's usually a high-risk surgery if they're really hyperthyroid, but I'm convinced I've saved a few lives getting emergent thyroidectomy done. And then in terms of what is thyroid storm, you can do this, you can name somebody to be in thyroid storm by doing a Birch score, and I'll show that to you. Score over 25 or more is suggestive. It is not a highly validated clinical tool, and so I don't lean on it much. I like to sometimes do it out of curiosity, and I think it's worth knowing what's on the list just because it helps you know what to look for signs and symptoms, but I don't hang my hat on this too much. I use more just my clinical overall impression. But these are what's in a Birch score, and it's worth just glancing at so you know what hyperthyroidism can do to you. So it can cause hyperthermia, and the worse that is, the higher your score is. You can get central nervous system defects, you can get diarrhea and jaundice, you can get tachycardia, high output heart failure, AFib, and a precipitating event. So that's what's on the Birch score. You add these up and you get the score at the bottom. So how do we treat thyroid storm? We use the kitchen sink. So we use multiple mechanisms to stop the hyperthyroidism. So we protect the heart with beta blockade, get the thionamide on board. So those are our top 2 things. You use methimazole essentially always, unless it's the first trimester of pregnancy or a critically ill patient in the ICU, then we use PTU. And that's because there's been rare reports in the past of methimazole causing a scalp defect in pregnant women. No one really knows if that's a cause and effect relationship, but because of that, that's what we do. Then you can start thinking about second line stuff, iodine solution, glucocorticoids, and then bile acid sequestrants have been shown to help a little bit with enterohepatic recycling of thyroid hormone. That's kind of a newer trick. Cholestyramine can be used. And these patients often make all of us nervous because they have LFTs that are elevated at baseline. Hyperthyroidism often does that. And so it can make me nervous to give them PTU or methimazole, but we tend to go ahead and do it, and they usually get better. Their LFTs usually get better. All right, last topic is myxedema coma. So this is like thyroid storm. It's a term used in an inexact manner. All I would say, so myxedema coma, that word implies all these patients are in coma. So obviously, that's going to be a very select population. I've had folks who were alert and oriented and had to be intubated due to severe hypothyroidism because of their poor respiratory drive. So I don't love the fact that the term coma is in there. I'd prefer just life-threatening hypothyroidism. And we often get called with folks that are pretty excited about a high TSH, and that's always interesting, but remember, that's not where the money is. So back to my T3 discussion, is the TSH, actually, if it's high, indicates that the patient's kind of healthy, that their pituitary is responding to hypothyroidism, and that can be a reassuring sign. My patients I've had that have done poorly or ill elderly who've had really low free T4 and free T3, like 0, and then these mild TSH elevations because they're so sick, their TSH is not going up. So they have a TSH of 10 with a free T4 of 0. That scares me a lot worse than a TSH of 50 in a low normal free T4 or mildly low free T4. So it's rare, the data, and we don't have a lot of data on this. So most often it's a patient with new hypothyroidism that's kind of plugged along and finally gotten sick enough that they tipped over and came in. But omissions of medications are common, again, more common in the winter. The term comes from a specific type of non-pitting edema. You can see that from albumin and mucin. You can see hyponatremia as low as 80 degrees has been described. Sorry, the first one should say hypothermia. 80 degrees has been described. Hyponatremia, hypotension, hypercapnia. Had one patient in the hospital service who was admitted for rhabdo 2 or 3 times, and on the second or third admission, thyroid function tests were checked, and that guy actually was in mixed edema and got intubated right after we discovered it. So rhabdo, always think about thyroid. And then facial puffiness. And so I'm a big fan of seeing these pictures. This is a great one. This is from New England Journal. So this is the lady when she came in, just looking terrible. This is mixed edema, and then looking wonderful after she's treated. Complete resolution of her mixed edema. Another picture just of what these people may look like. This facial puffiness, particularly around the perioral area, is kind of classic macroglossia. And then the loss of the hair is seen sometimes, the lateral third of the eyebrow. It's not always seen, so I wouldn't hang my hat on that. And that's another great. So this guy came in better, and then a couple of months later, looking back to normal. But just this look is very distinct. All right, so the key to mixed edema is recognize it. So that's why I showed those pictures. It's not something we think about all the time. Consider intubation. And then we give IV levothyroxine in a really big bolus initially. And the poor quality data we have right now says a little bit of T3 mixed in with this T4 is probably helpful. Because again, if they're sick, they got to convert this T4 to T3. So this does nothing until the body converts it. So there's a little data that giving this carefully can help. There's also some data that giving too much T3 is harmful, to cause heart attacks in these patients. And then you want to be really careful about rewarming. You don't want to do that quickly, or they can get collapse because if they get vasodilated too quickly, they can't keep up with that. And usually the hyponatremia self-resolves, so be careful about doing a really aggressive treatment for hyponatremia in the setting of someone with severe hypothyroidism, because they're going to pop up really quickly, so just be ready for that. And then consider glucocorticoids concomitantly for these folks, just in the possibility that they have adrenal insufficiency. Okay, so back to our questions, and I should finish on time. So this introduces the concept that some people find difficult. So you're called to the ER, and you basically had a patient who just hemorrhaged in their pituitary. So they've lost all pituitary function. So somebody tell me what they want to do, A, B, C, or D. Okay, so Shashi, correct. And so the reason that others are wrong, so you don't want to give fluids only because you're worried this person's just lost their adrenal function, right? They've lost their pituitary, so their adrenal's not working. So that's not good. One little question that people, this is confusing even to our fellows sometimes, is you can't do a cortisol stimulation test in an acute setting like this because if you lose your ACTH, it takes 3 weeks for the adrenals to atrophy and for you to fail a cortisol stimulation test, which is the exact same principle of steroid injection. It takes 10 milligrams for 3 weeks to atrophy those adrenals and cause you to fail a cortisol stimulation test. So in the acute setting, you would probably have a normal port stim and you could really be misled. So you don't want to get that. And then you don't want to start IV levothyroxine, because if you give levothyroxine in the setting of adrenal insufficiency, people can get really sick. They get vasodilated. And if you lose your TSH, you've actually got a few days before you have to worry about that. So really all you're worried about right now is, could this person have adrenal insufficiency, brand new? So you want to start that with your IV fluids. And then this person doesn't need fludrocortisone, one, because they don't have primary adrenal insufficiency, and 2, hydrocortisone has plenty of mineralocorticoid activity. Okay, your breast cancer patient on Megace, stopped, comes to clinic, she's nauseated, fails a quart stim, you give her hydrocortisone. What do you want to do now? Leave her on that and wean her off it in the future? Scan her head for a metastasis of her breast cancer to the pituitary? Okay, somebody went in. Yes, A. So this is basically the same as a glucocorticoid exposure. She's been on medicine that caused secondary adrenal insufficiency. It got stopped too quickly, and so we want to leave her on hydrocortisone, wean it off slowly, and she probably will recover. So a little too early to, I mean, you definitely in this patient would consider these as possibilities met, but this is by far and away the most likely explanation here is just megace. So just remember megace. And then again, don't need fludrocortisone. All right, which one is wrong for your ICU patient or your floor patient with severe Graves? And I forgot to number them, so just go A, B, C, D from top to bottom. Yes, so D's wrong. You don't want to don't do the iodine first. So you can see in all the others, oops, and I gave 2 wrong answers, didn't I? So I messed this one up. But so this one's wrong because you did SSKI before methimazole. You did it here too. So sorry, I should have reversed those. But so no SSKI. Oh, sorry, I got it backwards. Excuse me. So these are all wrong. This is the only right answer. Sorry, because all of them have SSKI before methimazole. So all these are wrong except C. So I posed the question poorly. So C is correct because you did methimazole first before your SSKI. The others are wrong. All right, last one, and then time for other questions. So on call in the ICU, nursing home patient, levothyroxine got left off their med list and transferred. C. Okay, correct. So why are the others wrong? So warming blanket, bad idea. You want to do passive rewarming in these patients. Don't want to do that too quickly. T3 alone has been tried, been shown to be dangerous. Levothyroxine IV, good idea with a little T3 thrown in, good idea. And then this is a patient, I'll just put a plug in for you guys. These patients can look pretty good, but there's a 30 to 60% mortality rate for mixed edema, and that odds that they need to be intubated are substantial. So this is one where you, I could envision I would want to put this person in the ICU, and you might get some pushback because they look pretty good, but these patients are really sick, and they sometimes don't look like it. I think, yeah, on time. So let me know questions.
So I got one question.
Yeah.
We use steroids both to prevent the conversion of T4 to T3, block the conversion, both in actually both in hyper and hypo. So when you're giving T4 in hypothyroidism or mixed edema coma or one of those states, are you inhibiting the conversion?
Yep. So that's a good question. It's a problem we face. So again, what you fear in those patients is if they've got mixed edema and it's from a pituitary source, which is not going to be as common, they could have loss of adrenal and thyroid function. So you get worried about that. So that's why we think throwing in that T3 is helpful, because then you're putting some T3 in the system. But you're right, you are inhibiting, not probably completely, but some of that T4 to T3 conversion. And then in patients with primary hypothyroidism, so high TSH, low free T4, occasionally they're going to have Schmidt syndrome, so they're going to have coexistent Addison's disease. So that's why we sometimes do the steroid. If the patient's stable enough and you can get a quick quart stem and avoid having to do that, I would, but sometimes you don't have that luxury. That's a good question.
Thank you.
Anything else? All right, thank you guys. Feel free to email me, write me, glad to help.
Thank you, Dr. Vaughn, for your time.
Thank you. See you later.